Coming to you from our headquarters in Cameroon's economic capital, Douala. Today, we are looking at issues concerning the new malaria vaccine imported into Cameroon by the Ministry of Public Health. Several persons are raising concerns and doubts about the Muscaris malaria vaccine and, of course, the efficiency and possible health complications that could emanate from the administration of that vaccine on children. The Ministry of Public Health has made available information on the content, the composition, and of course the side effects and the efficiency of that vaccine, but many are not still persuaded. We are also looking at the problem of the proliferation of counterfeit medicine, not only in Cameroon but across the African continent, with devastating consequences, thousands dying as a result of the consumption of counterfeit medicine. And of course, we are also looking at the issue, what has been qualified as the very thorny issue of medicine regulation on the African continent. Meet our guest in some few seconds. Today is Professor Henry FOMUNDAM. He is a pharmaceutical scientist with several years of experience in the United States and several African countries. He is a consultant to the African Union New Partnership for Africa's Development and the United Nations Economic Commission on Africa on Medicine Regulation in Africa. He is the lead consultant on developing the framework for the Africa Medicine Agency. He worked on clinical trials regulation in South Africa, and of course pharmacovigilance in the United States and several African countries. He is on faculty at Howard University in Washington, D.C., Stellenbosch University in Cape Town, and affiliated to other universities. Professor Henry FOMUNDAM joins us from Pretoria, South Africa. You're welcome, Professor.
Thank you very much. Not the best.
All right, we'll begin with the issue of the new malaria vaccine that's been imported into the country by the Ministry of Public Health of the Republic of Cameroon. The vaccine that is expected to be administered to protect children from the malaria health problem. And now the issue here is that the Ministry of Information or the Ministry of Public Health has sent out information about the composition, the efficiency, the side effects, and all other things concerning that vaccine. But many people are not still persuaded. Many are still raising doubts about that vaccine. What do you think about this uncertainty surrounding the Muscaris vaccine?
Well, thank you very much, Jonathan. I think I heard the question very well, but the connectivity is not the best. Now, the malaria vaccine, it's not just excitement, but a lot of euphoria for public health workers globally. Malaria is an age-old disease, which I could say in the 20th century, it probably killed about 300 million people. So it's a drug, it's a disease that has had all the scientists on their radar screen looking for how best to eradicate, how best to treat, how best to cure it. It's been very elusive, and that's why in the modern world, we have about 250 million people yearly that have malaria, and about 600,000 of them die. And unfortunate situation is that we have most of these people dying in sub-Saharan Africa. 94-95% of them are in sub-Saharan Africa. And about 80% of them are children that are under 5. So to summarize and to make people to understand better, our televiewers, you would say that about in every 2 minutes, there's a child dying in Africa because of malaria. So it makes it very difficult, although we have malaria therapies, chemoprophylaxis that is available. There are lots of WHO programs that want to eradicate, but that's not adequate. If you think about the fact that we have a child dying in every 2 minutes, the vaccine is a welcome approach. and it did not come overnight. This is the first vaccine, Mosquirix, RTSS, the other name, the chemical name of it. It's been in the works for the last 30 years. And so people are very excited. The drug is out, the vaccine is out. Like many other vaccines, we don't expect 100% efficacy. It would be good to get that. We've had 90-something% in some other interventions. In the clinical trials leading to these drugs coming to the market, it was probably about between 30 and 40% in the clinical trials, that, which means about 40% of the drug is going to work. But that mostly depends on the kind of endpoints that you're looking for. If the endpoint is reducing the number of hospitalization for the children, it's the severity of malaria in the children, and the number of, and decreasing the number of deaths is obviously. And so, based on that, 30 to 40% is good enough. We have that with a lot of cancer medicines, which we can even approve the medication when it's less than that. And in a situation where a child dies every 2 minutes, it's a very welcome approach to the malaria intervention globally and especially for Africa.
All right, the World Health Organization approved of that vaccine, the Mosquirix malaria vaccine, and the Ministry of Public Health of Cameroon has made available information on the composition, the efficiency, the side effects of that vaccine, but many are not still persuaded, possibly because they are seeing what the minister is saying as what is coming from a government official, a politician or an administrator. Now, you as a scientist that you are, what do you know about this Mosquirix vaccine that can be reassuring to the people?
So, thank you for that question. It's a very important question because the history of vaccine on this continent has not been very, very good. Globally, there's been challenges. We saw that with the COVID vaccine. So, first, I need to congratulate the Cameroon government, the Ministry of Health, for making an effort to bring the vaccine into Cameroon. Now, this vaccine was being tested in primarily 3 countries, Ghana, Kenya, Malawi. So they've had over 2 million children that have received this vaccine, leading to the results that the drug was approved, has been approved, pre-qualified by the World Health Organization since 2021. So we have quite some experience with the medication. And the expansion program, Cameroon was the first to be able to order these medicines. And so congratulations to them for that. However, what they haven't done well, which is the reason why you have this question, is that the advocacy before bringing the vaccine into the country has not been properly done. And the advocacy requires that the Ministry of Health, working through the regulatory authority for medications, will have been able to ensure that the population is aware of the vaccine coming, educate the population, and that's because vaccines always have a history. We've had in the early 30s, 1930s and things, we've known what some of the people have their issues of human rights. So people are usually very skeptical, and so it becomes very rife for misinformation and disinformation. However, from us, from the scientific world, this is a very welcome approach, and we do think to make sure that we can reduce the severity of malaria, the number of people that are dying, decrease the number of hospitalizations. That's wonderful, even if it's going to work 40% of the time. However, if you do a self-analysis, you see that in some of the age groups, up to 75% of the patients will decrease the number of malaria incidents that they're having per year, and will decrease the severity and the hospital admitted.
All right. Now, another issue here is that many Cameroonians are caught in between trusting the health authorities for the protection of their children against malaria and possible health complications that could emanate from the administration of that vaccine on their children. Recently, there was a case in the town of Kribi in the South region where a child developed serious health complications and almost unable to see, almost paralyzed as a result of a yellow fever vaccine. And that child was taken to India and brought back to Cameroon, and the health situation of the child has remained critical, and the parents have been crying out for help from the Cameroon government. And these are some of the issues that come up when we talk about vaccines, or when government begins to call people to go for vaccination to protect their children. Many are caught in between, trusting the government, trusting the health authorities for the protection of their children, and possible health complications that could emanate.
Okay. Well, that again is very understandable what people's concerns are going to be. But I probably want to say, of all the different classes of medication that we use, vaccines may perhaps be the biggest public health intervention and perhaps the safest drug that we've been able to use. Now, there is no drug that is free of 100% free of side effects. Now, in this case that I have also been able to read in the papers, there's what we call causality, which means how are we very certain that the paralysis came from yellow fever, which we have to eliminate everything else that was being suspicious, because there are a number of conditions that can make anyone paralyzed. Now, we don't have all of that data to be able to analyze. But coming back to the concern that people may have with the malaria vaccine, it's been used during the clinical trial, and then after that, it's been used in 2 million children in the 3 African countries that I just mentioned. So we have about 5 years worth of data of this medicine being used. And so if there are anything very untoward, severely untoward, like liver damage, like paralysis, we would have been able to pick up. However, it's not to say we cannot, we have to remain vigilant, because you may have a rare situation that you can put together a monitoring and evaluation team that focuses on the endpoints that you're looking for, but also more important, that we have a pharmacovigilance process in place. Every drug is going to have adverse drug reactions. But every vaccine, the Mosquirix vaccine, the most common adverse reaction will be pain in the site of injection, some fever. The normal reaction that you see for children who get vaccines is what has been reported for the last 5 years. So there's been nothing major that has been reported. And I think parents should be reassured, be educated, that it's better to take this to them a chance, because that's what they're concerned about. But there's data that we have, more than 5 year use of data, millions of children in Africa that have used it, and they've benefited from this in terms of reduction of the severity of malaria.
Right, you started talking about this. Let me just put forth the question so you can elaborate a little further on the importance of vaccination in ensuring good health for children and even for others. Vaccines in general.
I don't know if I get your question very well, but let me say something again about vaccines. This may answer the question that you have. Vaccines are known to perhaps save 3 million lives every year, because these are child immunizations that take place. We know of things that are diseases that have been eradicated because of vaccines. Smallpox, polio is remaining only in a few areas, which is a very terrible disease that affects your immune, affects your nervous system. We've had vaccines against hepatitis A, hepatitis B. So there's a lot of vaccines that we have now that are saving a lot of lives, but people don't actually put a hand to it because they're not aware of it. So we think that the line was not very clear.
Right, you answered the question. It was about the importance of vaccines in general in ensuring the health of children and even adults. Now, Most of the vaccines that are administered on children in Africa and even on adults are imported. Can Africa not produce its own vaccines?
Sure. So this is the bad news, and I think this is what we all would be guilty of as African scientists, particularly in the pharmaceutical space. It's only 1% of the vaccines that are used on this continent that are actually manufactured on this continent. So we are importing about 97 to 99% of the vaccines that we use on this continent. It's a little bit embarrassing, but that's something that we need to address. The two malaria vaccines that have just come out, developed in the UK, the first one was created by GSK. They've partnered with Serum Institute of India. They didn't partner with any African country, and that's because in Africa we don't have the infrastructure yet that will be able to produce that. A number of countries and a number of programs are working on that. That we need to be able to be in pole position, developing our own infrastructure, making sure that we have the funding available, making sure that we have the employment sector working with our governments to set up those kind of infrastructure that will make it attractive. Because at the end of the day, the pharmaceutical companies are looking for people that will be able to work with them. It's a business, it's profitable, it takes care of patients, daily life. So they want to make sure that they can use infrastructure that is existing, and India is the one that is doing that. And for the second R21, which has also been approved by WHO, the second vaccine for malaria, the company, Oxford University, is partnering yet again with another Indian company, Bharat Biotechnology, to make sure that these drugs are going to be produced. Now, when you are producing a vaccine, the most important component of the vaccine is what they call the antigen. The antigen is that component of either, in this case, the parasite, which is or a virus or bacteria, that component that will trigger your natural defense mechanism to be able to produce antibodies. So you take that component and you're able to, through recombinant technology, create it within your manufacturing space. And that's what will be used now in developing the vaccine. Now, most of the African countries, what they're doing is not working on that active component. They're able to put it together for you, but we need to go beyond that. And so, yes, we are all guilty of it, and that manufacture vaccine. The governments and the private sectors need to make sure that they get together, create that infrastructure that will be very attractive to drug companies so that vaccines can be manufactured. Local manufacturing is something that the African Union is really working on. Not only local manufactured vaccines, but all the other medicines that we're using. Majority of them are still also imported. And this is a pharmaceutical space that a world developed, it should be able to create about 16 million jobs in Africa. So we are missing an opportunity to take care of our patients. And because we import most of the medicines, we're very vulnerable to counterfeit, what you call counterfeit medicines, substandard or falsified medicines. So that's the challenge that we have. We don't have the resources, we have not put the resources, we have not prioritized it. So the government and the private sector must get onto the table in order to make sure that we produce these drugs, because they will become cheaper, there will be a reduction in the counterfeit medicines. That's what we need to do at this time.
Right, let's go to the newsstands now, and we are taking a look at what the newspapers reported this week in Cameroon. And after the press review, we are analyzing the proliferation of counterfeit medicine across the African continent, the deadly consequences, thousands dying as a result of the consumption of counterfeit medicine, and of course, we're also looking at medicine regulation on the African continent. Municipal updates 2023 third quarter report reveals over 200 murder cases in Cameroon and in the crisis-stricken northwest and southwest regions. News Watch says killings galore as armed conflict fades from global gas. And in the horizon, international lawyer and peace crusader Ntumfo Barrister Nico Hale calls for immediate Christmas ceasefire in the restive Anglophone regions. On the front page of the Post-Weekender, city dwellers stranded as fuel scarcity grips Yaoundé and other towns. And Municipal Update tells its readers that government will tax digital assets in 2024 at CRM elective convention. Opposition drums fresh coalition to unseat Biya. And during that convention, Professor Maurice Kamto got another mandate as national president of the Cameroon Renaissance Movement with a score of 99.23%, as reported by Eden. And the reorganization of the Social Democratic Front in Teko Southwest region now slated for March 2024. This is reported by The Sun. The paper also carries the story on palm oil plantations board, which adopted 12.2 billion francs CFA as company's budget for 2024. Cameroon Echoes highlights steps being taken by the mayor of Idabato in the southwest region to modernize the municipality to the benefit of the population. Municipal Updates reports the unveiling of the ultra-modern Government Technical High School Marwa by Prime Minister Chief Dr. Joseph Dangote. The Guardian Post reports that on an evaluation mission to the East region of Cameroon, the Interim Minister of Mines, Industries and Technological Development, Professor Fukalistus Gentry, saluted work progress on the Kolomine gold mining project. The Voice Weekender presents the top 50 personalities who marked 2023, including international lawyer and anti-corruption crusader Barrister Kerimuna, late founding national chairman of the Social Democratic Front, Ni John Frundi, Prime Minister Chief Dr. Joseph Dangote, international lawyer and peace crusader Ntumfo Barrister Nico Hale, Senior Associate for Africa and Regional Director of the National Democratic Institute for International Affairs, Dr. Christopher Famia, Professor Maurice Kamto, National President of the CRM Political Party, Professor Fukalistus Gentry, Interim Minister of Mines, Industries and Technological Development, Heavyweight Champion Francis Ngannou, and others. Cameroon Tribune projects efforts by the Minister of Transport, Massinangale Bibehe, to curb accidents on highways across the Republic of Cameroon through a road safety campaign launched on the Yaoundé-Douala Highway to ensure a safe end of 2023. According to the Guardian Post, Cameroon avoids UN vote for humanitarian ceasefire on the Israel-Gaza war. That was the press review. Thank you for staying with us. We are still with our guest, Professor Henry FOMUNDAM, pharmaceutical scientist with several years of experience in the United States and several African countries. Now, Professor, what is your analysis of this problem of proliferation of counterfeit medicine across the African continent with the deadly consequences that come with the consumption of such medications?
So the issue of counterfeit medicine is actually very, very big on this continent. This is the continent that has the highest counterfeit market. The counterfeit market globally is about $200 billion. So there's a lot of money in it, and so it's very challenging to make sure that you can control it. The counterfeit market is probably about 10 to 15% globally. But in Africa, it could be as high as 40%. And with some particular medications, we've seen up to 70% that is counterfeit. Talking about malaria, the number of studies that have shown that we could be globally losing people who are dying because of up to about 200,000 or 250,000 people that are dying because of counterfeit malaria medication. And so various studies in different countries are showing that there's a lot of counterfeit medicine. Why Africa? Because we have weak regulatory systems, we have porous borders that cannot be controlled properly, the deaths that are coming in, but we also have very weak monitoring systems. The pharmacovigilance is very weak, on the continent. And above all, we also have a lot of corruption in the African countries where drugs are registered irrespective of the efficacy of the drug, of the safety of the drug. We also have a situation where once drugs are registered, the regulatory authority, either by omission or commission, do not go back to the supplier to check sporadic monitoring, like the WHO does for the pre-qualification program, where you can go back to the manufacturers and actually look at what is the supply in the market. Even after we register them, it could be after 2 years, it could be after 3 years. So there are a number of multiple factors that are contributing to the fact that we have a lot of people that are dying on this continent because of the proliferation of counterfeit medicine. They're all over the place. We all know that, and all the governments are struggling with it. But in my view, they're not struggling enough. And the general public sector and the consumers need to be educated enough to partner with the government to make sure that the counterfeit medicine are significantly reduced.
Now, the high cost of medicine sold in authorized and regulated bodies or institutions, companies, pharmacies, hospitals, seems to be an enabling factor pushing many people to the streets to buy medicine that is not regulated, or that's not been controlled, that has not gone through the control mechanism put in place by the states.
So I heard the first part of the question, which you're talking about the cost of the medication. I would answer, and let's see whether I've answered the entire question. The connection is not the best. So the cost of medicines on this continent is very prohibitive. That's why we designed to using what you call generic medicines, which are the cheaper versions of the medication. They are good, but cheaper is not always the best. Sometimes the brand names may be more expensive, but they end up being cost effective. Like if you use a cheap medication for diabetes, for example, and if the medicine is not, that person is going to be going into the hospital very often. And if that happens, if you add up the cost, it makes it not actually cheap. But the cost of medication is not well controlled in most of the African countries. So you would not unusual to see that someone has a markup of 200%, 300% on a medication that is used on a continent that has less resources like Africa. So the governments have to make sure that they do a price control on the medication that are coming into the various countries, because a markup of 200%, 300% is very, very unaffordable. And again, this is a continent where most of the payment of healthcare is out of pocket. So you have about 75% of the people paying out of pocket. And there's something called catastrophic health expenditure, where someone is newly diagnosed of cancer, and suddenly 80% of your income is going towards one disease, or towards your healthcare. That's unacceptable. That's unacceptable. It affects the quality of life. And those are some of the things that are found that the government has to step in terms of looking at the cost of medication. They have to apply so that you have one exit price from the pharmaceutical company and one exit price from the distributor, and they have to also control how much is markup at the various pharmacies that exist in the country.
Now, the African Union has created the African Medicine Agency, similar to what has been established in the European Union. Is that a solution? Can that help to regulate in medicine regulation on the continent?
So that's a very good question. Everybody's looking forward to the African Medicine Agency, which is created by the African Union. This was created since in 2019. Out of the 55 countries in Africa, 27 of them, soon to be 28, have ratified, which means they've agreed, they've signed up to become that. Now, having a continental medicine agency that we have in Europe, Europe has 27 countries. and perhaps 3 more from the European Economic Area. So making about 30 of them. But these are countries that have a very high GDP, they have issues, they have the good expertise, they have good infrastructure, they have good financing. And so medication, registration and control and monitoring in Europe is very, very robust. It's several classes of medicines that are approved by the European Medicine Agency that takes care of the entire European countries. So it's the same concept that the African Union sought to come up with, to say, let's come up with an African Medicine Agency on the continent, which is going to be based in Kigali in Rwanda. And the idea is that they should be able now, through the African Medicine Agency, help the different countries to strengthen them in terms of the medicine regulation. And because each country may not have the capacity, both in human resources and financial resources, the African Medicine Agency will be able to assist the countries in how to regulate, particularly very complex, particularly drugs like for cancer and drugs that may have to do with pandemics. So the African Medicine Agency is a very, very, very welcome approach. The implementation is what we're going to be working on, and as the lead consultant on that aspect, we're going to be looking at what is the best way to ensure that the African Medicine Agency can work with the 55 member states to ensure that medicine regulation is the best. And some of the challenges that we find is that in some countries it takes about 3 years, 2 years, 3 years to register a medication. In that period is the patient that are suffering. So the African Medicine Agency would be attempting to correct and contribute to all of this. Also, they have an agenda to make sure that they are promoting local manufacturing on the continent, they are promoting food procurement, which means getting a number of African countries to buy together. The economies of scales needs to kick in to make sure that when you're buying together as maybe 10 countries, 20 countries, you can reduce your cost by about 40 to 70% if it's done properly. So the African Medicine Agency would be a major addition to how medicines are used on the continent, and hopefully the product pharmaceuticals are be able to reduce some of the side effects and some of the counterfeit medications that we're having on the continent.
You just came back from Cairo, Egypt, for the 6th Scientific Conference on Medical Products Regulation in Africa, and the focus of that encounter was strengthening regulatory systems for the advancement of local production and increase access to medical product and technologies for Africa. What are some of the expected fallouts of that meeting in Cairo?
So the African Union Development Agency called NEPAD organizes a scientific conference, I think every 2 years, and brings together the pharmaceutical scientists, the best on this continent and all over the world. Their goal is to look at how do we begin to make sure that we can improve on research and development. We don't have innovative medicines that are coming out in Africa. You can see the malaria medicines now, they came from research that was done in the UK. Artemisinin for malaria came from China. So all of these innovative things are usually not coming from Africa. And there are a number of reasons for that. So the scientific conference like this is looking like, how do we remove these barriers to make sure that Africa can begin to carry on research on its own medications, on its own diseases. We have a group of diseases in Africa that are called neglected diseases. Neglected diseases because it's been neglected by the funding agencies, not by Africa. It's been neglected by funding agencies. It's been neglected by the pharmaceutical companies. And we're saying we should stop calling them neglected diseases because Africa is going to focus on it. But for Africa to focus on it, we need to make sure that the government is on board. We need to make sure that there's financing. We need to make sure that there's transparency. We need to make sure that we develop the infrastructure so that Africa should be able to carry on its own research. But above all, the regulators were all present, from Cameroon, from all the other countries were all present in Cairo. what we are looking for is how do you make sure that you can register your medications on time, you can make sure that all the medications that you have, you can monitor them, vaccines like the new ones that are coming. How do we review it? How do we make sure that we educate our population to be able to do that? So it was a number of things. The WHO was present, EMA, which we spoke about, the European Medicine Agency, lots of international organizations were all present. The US FDA was present. A number of people were there to make contributions to this scientific development for Africa.
What are some of the changes that Africans can expect in terms of production and technology in the coming years?
We're in a very good space. It's taken a long time to get to this space. Africa is going to be partnering with a lot of international organizations. The international funders are going to be helping, but we want to make sure that this is done in a sustainable way. In the next several years coming, we should begin to see local manufacturing build up in Africa. And we even struggle with the definition of local manufacturing. It's manufacturing in Cameroon for the use of medicines in Cameroon. Is that what you mean by local? No. The definition of local is going to be probably be modified to mean that if Cameroon produces it, it should be for Africa. And that's why you have the African Continental Free Trade Area, because they want to make sure that if goods are manufactured in Cameroon, you should be able to sell it anywhere on the continent, tariff-free. And so, but 60% of that drug should be made in Cameroon or made with ingredients that are coming from Africa, in order to make it a truly African product, which would be distributed without any taxes throughout the continent. So there are a lot of things that are coming out, which I will probably say watch the space, because there are a lot of changes that are happening in medication use. But we cannot do this without coming along with the consumers, with the people in the communities, which is now the onus on the government to be able to educate people. Like I said, they haven't done enough in the malaria vaccine. We have to have a model that you have to do advocacy in the communities and make sure that people understand why and how. So we're also trying to make sure that medicine regulation should be brought closer to the people, closer to the communities.
We're going to take some interviews now, and we'll be right back in some few minutes.
The transformer that carries this quarter is small. The population is big. So whenever the transformer is having a problem, they try to amend it, but it cannot go because that same transformer that is small, they bring it back, and just not up to a month, it will still get bad.
The embarrassment of thieves, they are taking advantage of this light, no light. They harass people on the way, people who are living far, when they come late, they want to go back, they harass them, seize their bags, particularly women.
We can conclude that things are coming back to normalcy. We have had sporadic attacks left and right because the criminals and the terrorists still want to give that impression, the false impression, that they are still very active. We say no. We want again to thank the population for their collaboration. It is important for them to collaborate. And we want also to tell the motorbike riders who are responsible to join us in this fight. The motorbike riders, they should never again be a sector that these criminals can use to commit atrocities. We will, as from January, go into serious identification, and those who are not identified after the given period will not exercise that profession as motorbike rider.
We are not able to sell our products again concerning like beer. I'm selling ice cream. I can't even sell. Today was the end of the year. Parents were taking the children report card. I was unable to sell my glass, my ice cream.
Coming back from Manchester and travel, I could not reach their house because of petrol. It's very, very, very surprising that It's just like you have food in your house but you cannot eat. Because we have petrol at Limbe. But here in Douala we cannot use it. It's very, very surprising, and many others are suffering. I will take this privilege, use this privilege to tell Cameroonians that really human government has failed. So let's see how we can rely on God's government, because human government has failed, especially Cameroon government, because it is really, really surprising that Cameroonians can lack petrol in their own country.
What do you mean by relying on God's government? Will God come down and govern us?
Well, if we want to enter into details or that, it will take us a long time. I want to be briefed that if you see what the Bible say about government, it is a promise that God will set a government that will rule better than human government. And people cannot have this type of problem in that time, during the appointed time that God has set aside to take over human government.
How has this issue affected your activities, your business? Have you incurred some loss in income because of this?
It ridiculed my business, everything. As I'm here like this, what am I doing? Everything stopped because I'm here, because of petrol. Everybody's crying, not only me, as you can see. See how people are scrambling here because of petrol. I would have been in the housings, but I'm here under the sun. I don't even know when the petrol will come. They are still waiting for the truck that will deliver petrol here before people can save us. So it is, even in the house they are suffering, in the business place they are suffering, at my job site they are suffering because of petrol.
Thank you.
It is very, very, very surprising for us to have this type of problem, because we know we are producing petrol. That's why I mean by having food and not able to eat.
What are you expecting from government now?
Well, the government should make effort. They should make effort to see that this type of problem could not happen again. I know humans are imperfect, but there are certain things that should not happen. Like, for example, petrol. Cameroon should not have problem with petrol because they are producing petrol. They should not have problem with petrol. It's like you have food, but you are hungry, but others are eating. Because the white man is using our petrol, but we are not using it.
How difficult has it been for you for these past days to obtain fuel?
No, it's terrible. It's terrible. Maybe the government want us to die. They want us to die. No provision, nothing. How can people suffer like this, and the government, they are just silent? Them, they have petrol. We are suffering here. They are not doing anything. We are suffering. To work, you will suffer, but after they will ask you to pay taxes, you pay taxes, you pay papers, you pay everything. But to have petrol to work, to ensure the security of your family, you cannot. It's terrible.
How has it affected your transportation business?
This is the time I'm wasting now to have a petrol. It's a time that I was supposed to carry people to have my money. That money to help my family to survive. But I'm here because I want petrol. This time I wasted. It's a time that it was supposed to gain. I'm coming from village, far from village, no petrol. From village, no petrol. Dorbasi, no petrol.
It was not easy. We had to struggle and moving up and down to look for the fuel. We had to reduce our movement to manage what the little that we have. It could have been nice to have a personal oil in the country, so that to avoid this situation, this type of situation.
All this is simply because we depend on the importations, and we can solve this problem by refining our own oil here in Cameroon. I think if we are refining our own oil, then it's only when there will be no communication in between the refinery point and the rest of the country that we might face a problem. And even then we can find a solution. But the minister is simply saying that he's confirming that the fact that we depend on importation tomorrow that problem can really happen. I won't even want to give him reason. That can really happen. Let's assume that we have a real problem of logistics around the world, like what happened during the COVID-19. You see what happened? All the vessels were stuck at the port, and then the importation was very high, and the cost of importation was very high. So we have to really cut our dependence on the importation. We have to go out of that because we get all the natural potential. We are oil producers. Why can't we refine our own oil? As long as we will depend on the importation, then we will have a problem. We will face problems.
You welcome back. Those were interviews of the week. Professor Henry FOMUNDAM. I want us to address the concerns of a good chunk of Africa's population who have very limited access to medical care, who have very limited means, who are caught in the web of poverty and are unable to access medication, especially those who are in the rural areas far away from the urban centers. How is the strengthening of Africa's medicine regulation system and the advancements in production and technologies going to address the concerns of these persons?
That's a very loaded question. You want to start answering that question by answering that why do they have limited access? They have limited access because some of it is because of the infrastructure they have in the country. And if you talk about infrastructure, you may actually put it on the footstep of some of the governments for not prioritizing a lot of the interventions that they have in the country. It could be because of financing, and again, how you talk about financing on the African continent, you always cannot shy away from talking about the corruption. How much money is lost, which should be used towards the healthcare. But generally speaking, we'll see that in the African countries, not enough attention is paid to the fact that education, healthcare, these are the two critical aspects that we need in every country. And so most of the countries are being asked to reprioritize. And in the rural area, what you didn't mention is the fact that they don't even have expertise, because a lot of the people are moving from rural areas to urban areas. But a country like South Africa has done is give what they call allowances, rural allowances, to attract doctors, nurses, pharmacists to be able to work in rural areas. So we don't want to come with an African, this is where we're talking about African solution for African problems. What is it that we can do to be able to perhaps even use technology to mitigate that? In Rwanda, for example, medical supplies rural areas is done by the drone. There's no reason why you cannot have a drone that flies from, say, Yaoundé into the hinterlands or into other places just to supply medication. So we have to become innovative, we have to become more transparent, we have to become more accountable, because some of these aspects is contributed by the corruption, some of it is inadequate prioritization, where you don't prioritize healthcare and education, which are the most important aspects that we have in the country. So the rural area have peculiar challenges. They also have issues with communications, data gathering, surveillance. We don't have all of that. And it's up to the government to be able to partner with the private sector, especially. African governments are not partnering very well with the private sector. They need to be having more respect with the private sector and more interaction to help rural areas like you described.
Professor, thank you very much for your time.
Thank you very much. Thank you.
That was Professor Henry FOMUNDAM, pharmaceutical scientist with several years of experience in the United States and several African countries, talking to us from Pretoria in South Africa. And this is where we end this edition of The Insight, coming to you from our headquarters in Cameroon's economic capital, Douala. You can follow the rebroadcast of this program on Friday at 5 p.m. You can also follow us on our YouTube channel and on Facebook. Goodbye.